Hi, everyone. My name is Joseph Shaw. I'm a hematologist and thrombosis medicine specialist at the Ottawa Hospital. Both Dr. Jim DeKettis and myself are co-principal investigators on the PAUSE-2 study. I'll be taking about 10 minutes today to provide you with an overview of the PAUSE-2 study, and I'll be focusing on key aspects related to implementing the study at your center. The PAUSE-2 is a randomized control trial evaluating two different perioperative anticoagulation management strategies in DOAC-treated patients having either a high bleed risk surgery or an invasive procedure requiring neuraxial anesthesia. The perioperative management of DOACs is well established and is generally considered safe. But that being said, patients undergoing high bleed risk procedures are at higher risk of intraoperative and postoperative bleeding complications, and so there's greater uncertainty as to how to interrupt and restart DOACs in this patient population. Along the same lines, bleeding complications related to neuraxial anesthesia can be associated with potentially devastating effects. Neuraxial anesthesia includes both spinal anesthesia as well as epidural anesthesia. And because these anesthetic modalities can very rarely lead to bleeding into the epidural space, there's obviously a lot of interest in trying to establish the safest possible approach to managing directional anticoagulants in these patients. This is the procedural bleed risk stratification published by the ISTH. This is the same risk stratification used by the CHEST guidelines. And these guidelines use a three-tiered stratification approach where procedures are either considered minimal bleed risk, low bleed risk, or high bleed risk. Perioperative DOAC management decisions depend on whether a procedure is considered low to moderate bleed risk or high bleed risk, with generally longer interruption intervals for high bleed risk procedures. I'm highlighting the high bleed risk procedures here just to give you an idea of the types of studies that we would be aiming to include in the PAUSE-2 trial. And just to highlight that based on this procedural bleed risk stratification, any invasive procedure that involves neuraxial anesthesia is automatically considered a high bleed risk procedure. The DOAC perioperative management is largely informed by results from the PAUSE study. So the PAUSE study was a prospective perioperative DOAC management study of patients with atrial fibrillation and was carried out by Dr. DeKettis and colleagues. Perioperative DOAC management in the study was determined based on procedural bleed risk, DOAC pharmacokinetics, and renal function. And the perioperative management strategy used in this study can be seen on the right. I've highlighted the management used for high bleed risk procedures in the red squares. And as you can see on the right, DOACs are usually interrupted for 2 days before high bleed risk procedures and restarted 48 to 72 hours after the procedure, provided hemostasis has been achieved and neuraxial anesthesia has been discontinued. Now, this strategy is simple, it's easy to implement, and it was found to be safe. The PAUSE study found a relatively low risk of major bleeding at 30 days after the procedure, and it tends to be preferred by internal medicine specialists. So an alternative strategy, which I'll refer to as the ASR strategy, this stands for the American Society of Regional Anesthesia. The ASR approach is contrasted with the PAUSE approach, as you can see on the right. This strategy is used for neuraxial procedures, but is also often applied towards high bleed risk procedures. This ASR approach is more complex and very cautious as compared to the PAUSE approach, with longer DOAC interruption intervals. And generally, DOACs are interrupted for at least 72 hours and potentially as long as 120 hours in the case of dabigatran, as you can see on the right. The ASR approach also includes considering bridging therapy for patients at high thromboembolic risk due to these longer DOAC interruption intervals. You might be thinking to yourself that these two strategies sound fairly similar, and generally there's only about a 24-hour difference in the interruption interval between these two strategies. So what does it really matter? But that's part of the point, and that's what we will be aiming to prove with the PAUSE-2 study. The problem is that despite the fact that these two protocols probably lead to very similar residual DOAC levels at the time of surgery, some patients are having their surgeries postponed or canceled because their DOAC treatment was not held for 72 hours pre-op. And this was a survey done by Dr. DeKettis and colleagues in 2019. This survey revealed that there are strongly held beliefs on each side of the internal medicine and anesthesiology divide, and this is what leads to clinical equipoise. This is why a trial is needed to harmonize these two different perioperative management strategies. The PAUSE-2 trial will be a multi-center international RCT. As I've already alluded to, this study will be focused on DOAC-treated patients with AF or VTE who require interruption of their anticoagulant for either a high bleed risk surgery or any invasive procedure requiring neuraxial anesthesia. Patients will be randomized to either a PAUSE-based management strategy or an ASRA-based management strategy. As you can see on the right, PAUSE-2 will use a probe design, meaning that allocation of one management strategy or the other is open label, but the outcome adjudicators will not be aware of which management strategy patients have been assigned to. These are the PAUSE-2 eligibility criteria. Again, we are aiming to recruit adult patients with either AF or VTE who are prescribed a full dose DOAC. Eligible DOAC regimens are shown on the right. And the key here is that if the patient is on a lower dose DOAC, but this dose reduction is because of formal dose reduction criteria. So for example, a PIC-SPAN 2.5 milligrams twice a day in a patient with AF and an age over 80 and a serum creatinine over 133 micromolar, this would still be considered a full dose and the patient would be eligible for enrollment. That being said, if a patient is on a PIC-SPAN 2.5 milligrams twice daily for long-term VT prevention, then this would be considered a true lower dose, and so these patients would be excluded, as you can see for the exclusion criteria number 2 below. As previously mentioned, these are patients having a high bleed risk surgery or any procedure involving neuraxial anesthesia or a deep nerve root block. I won't go over each of the exclusion criteria in detail, but you can see that patients with unusual site VTE, like splenic vein thrombosis, as well as patients with renal dysfunction are excluded. The last exclusion criteria means that patients should only be included once in the PAUSE-2 trial, and this was done for statistical reasons. So as shown here, patients are randomized to either the PAUSE management strategy or an ASRA-based management strategy. But what exactly does PAUSE management and ASRA management entail? So PAUSE management in this study will be considered in the intervention arm in the study. PAUSE management for the PAUSE-2 study will be the same as for the original PAUSE study. The management strategy is outlined on the right. So for a PIC-SPAN, a DOC-SPAN, or rivaroxaban, you stop the DOAC for 2 days before surgery. This means, practically speaking, that the last dose of DOAC will either be on the evening or in the morning of preoperative day -3. Then DOACs are restarted 48, 72 hours post-op, provided adequate hemostasis has been achieved and neuraxial anesthesia has been discontinued. So again, for the PAUSE arm for dabigatran-treated patients, the instructions are the same for patients with a creatinine clearance of over 50 milliliters per minute. But for patients with moderate renal dysfunction and a creatinine clearance of less than 50 milliliters per minute, 2 extra days of interruption are added, as was done in the first PAUSE study. This is because dabigatran has greater dependence on renal elimination. So that's why there's this stratification here based on renal function. So in this case, for a dabigatran-treated patient with a creatinine clearance of less than 50 milliliters per minute, the last dose would end up being on the evening of pre-procedure day -5. It is important to highlight that although formal bridging isn't done in the PAUSE intervention arm, the use of postoperative subcutaneous low-dose prophylactic low molecular weight heparin for VTE prophylaxis for 1 to 2 days prior to restarting their usual oral DOAC dose is allowed. Now, the control arm in the PAUSE-2 study will be the more conservative ASRA management strategy. This means that the last dose of a PIC-SPAN and a DOC-SPAN should be given no later than 72 hours before surgery, as recommended by the ASRA guidelines. So in other words, there has to be a minimum of 72 hours off the DOAC before surgery. And practically speaking, this means that the last dose would end up being in the evening of preoperative day -4, or in the morning if they take rivaroxaban and they take their dose in the morning. So again, slightly different instructions for dabigatran depending on the participant's renal function. There's a lot of details here, but the point of this slide is just to show you that Although dabigatran will be less common than the factor Xa inhibitors, if you do have a patient on dabigatran, you should check their creatinine clearance for these patients and incorporate that into assigning a perioperative interruption interval. So generally, as patients go down in these different strata for renal function, there's 24 hours or 48 hours that's progressively added to the recommended interruption interval, as you can see on the left here. And as previously mentioned, the ASRA management strategy allows for bridging in select high thrombosis risk patients. The decision to use preoperative bridging will be at the local investigator's discretion. Importantly, this should be low-dose prophylactic bridging, given that these are DOAC-treated patients. It's very important that the last dose is given no closer to surgery than the morning of the day before surgery. So in other words, the morning of preoperative day -1. But just to give you some examples of what might be considered high thrombosis risk, this could include a patient with a stroke or systemic embolism within 6 months, or a prior perioperative stroke, among others, as you see here. And again, just to emphasize the types of dosing regimens of prophylactic dosing we would consider for this trial. You can see enoxaparin 40 milligrams sub-Q once daily, dalteparin 5,000 units sub-Q once daily, or tinzaparin 4,500 units sub-Q once daily, usually given in the morning for 2 to 3 days before surgery. Again, the last dose should not be any closer than 24 hours before surgery. So the main measure in the PAUSE-2 RCT will be based on that citrated plasma sample that will be collected preoperatively. The primary outcome for the PAUSE-2 RCT will be the proportion of patients who have a negligible DOAC level. And for the purposes of PAUSE-2, we considered a DOAC level of less than 30 nanograms per milliliter to be very low. This proportion will be compared across PAUSE versus ASRA management arms, and our sample size was determined based on a non-inferiority hypothesis, meaning that we hope to prove that PAUSE is not worse than the more conservative ASRA approach. The hope is that these two strategies result in a similarly high proportion of patients with a residual DOAC level that's less than 30 nanograms per milliliter before surgery. We will also be measuring several secondary outcomes. This includes the proportion of patients with a residual preoperative DOAC level of less than 50, as well as standard clinical outcomes, including ISTH-defined major bleeding, clinically relevant non-major bleeding, and thromboembolic events, as you see here. This diagram shows the standard study visits. So participant consent and enrollment would occur on visit 1, as well as baseline data collection. Visit 1A really only applies for those ASRA participants where the investigator has decided to give preoperative low molecular weight heparin bridging. So this would be a teaching visit to make sure that patients know how to inject themselves if that's deemed to be warranted. Visit 2 is mainly for the preoperative plasma sample collection. So that's the actual day of the surgery itself. Post-op follow-up occurs at 4 weekly visits, as you can see here. These visits are primarily for outcome ascertainment. These visits can occur either in person or by telephone. And there's also a very short patient satisfaction survey that is administered on visit 6 at day 28. So this is just to show you the various PAUSE-2 sites that we have approached and who will hopefully be recruiting for the PAUSE-2 trial. So again, PAUSE-2 is going to be an international RCT, and we're going to be including several sites in Canada, the US, and Europe. So thank you very much for agreeing to recruit and to participate in the PAUSE-2 trial. We're hopeful that the PAUSE-2 trial will give us better data and more data on this important clinical question. We're also hopeful that we can harmonize these divergent DOAC perioperative management strategies and ultimately improve patient care. But with that, thank you again for your attention. And if you have any questions or concerns related to the conduct or recruitment for the PAUSE-2 study, please do not hesitate to reach out to either myself or Dr. TTISS or our fantastic research coordinators. Thank you.